So the first speaker, Dr. Walid Kadru. Dr. Walid. Assalamu alaikum wa rahmatullah. Is it recorded? Yes.
Good evening, everybody. It's my great pleasure to participate in this great symposium. I'd like to thank the organizing committee for the nice invitation, and also I would like to thank them for this nice topic that they picked that for me. Anyway, I'll start with two pessimistic slides. Whenever you talk to a cardiologist about radiation issue, I think this is their approach. This is not my job. I try to ignore that. And I used to do that at the beginning of my interventional career. However, I started my interventional career in 1992. However, after I took the American Board examination in interventional cardiology, I found that around 10% of the question of that exam is about radiation safety and radiation physics. So it is very important to keep that in mind so you can understand the radiation physics and the radiation protection. The other pessimistic slide, whenever you are talking about such subject to the audience, you'll, I think about 57 to 60%, they are running sexual fantasy, and the other thinking about domestic incident, 7% will be blank, and only 3% will be listening. So at least I'll try to convey the message to those 3%. Now I'll go to the main slide, and it is why. So nobody would like to put his hand under the radiation and see this disaster effect on the finger and the skin. Everybody knows that the radiation is bad, and it can hurt the patient, and it can hurt the cardiologist who's doing the procedure. For the patient, it may cause skin injury, and it may cause even cancer. However, if we concentrate on the doctor, we'll find that there is increased incidence of cataract in the doctor who's doing this procedure. And the incidence of cataract is probably a threefold compared to the control physician who doesn't do intervention. And also the incidence of brain tumor, and especially glioblastoma, is increased. Beam. There are other complications from radiation that probably some of the doctors are not aware of. We know about the cataract, we know about the incidence of cancer, but we probably nobody thinks about the orthopedic illness because of radiation protection and the heaviness of this lid. Skin lesion also is increased in the interventional cardiologist. Hypertension and hypercholesteremia, and probably atherosclerotic disease because of direct effect of this radiation on the intima of the arteries, and it may cause oxidation of the LDL and may cause intimal thickening and plaque formation. So there is a risk of increased myocardial infarction and atherosclerosis in the interventional cardiologist. Now, how can we reduce this radiation dose? There are four measures: decrease the intensity of radiation, decrease the time, increase the distance, and use the shielding. Let's talk intensity. How can we reduce the intensity of radiation? There are important measures. First of all, to keep the tube away from the patient, and this is the best way. And the other one is to keep the II or the image intensifier very close to the patient. That's prevent any scattered radiation. So by positioning the table at the right position and the tube at the right position and the image intensifier or the detector in the right position very close to the patient, that's reduce the radiation dose. The other thing is to use the fluoro-save instead of doing cine, because the amount of radiation with cine is probably 10 times the amount of radiation coming from fluoro alone. So you can use the fluoro and use the fluoro store function in order to prevent a frequent thinning, especially if you are doing frequent balloon inflation or frequent monitoring of the wire position. The other thing is to use collimation. Collimation is that the shutter that come from the tube and concentrate the radiation beam on one area and prevent scattered radiation around the area. And I use that even in the diagnostic coronary angiogram, because using the shutter give you better image quality and reduce scattered radiation. So this is the summary the opportunities for dose reduction is to use collimator, and the collimator, you know, it's underneath the table on the X-ray tube. They use the filtration on the tube itself. You may use the grid, and the grid is a plate put between the patient and the image intensifier, and that's prevent scattered radiation to the operator, but however, it may increase the radiation dose to the patient. If you have the ability to buy better X-ray machine that has automatic adjustment of the radiation dose, it is really worth it. There are this study comparing different machine and showing that there is the amount of radiation dose differ from one machine to another. The other thing is to use technology to prevent more radiation. So the technology will make the radiation concentrate on the area where the catheter tip is moving and give less radiation around the catheter, since there is no need to concentrate on that area. Let me show you this video. You see here, this is the radiation concentrating at the tip of the catheter, and the radiation around this area is really reduced because we only concentrating on the tip of the catheter itself, and that will reduce the scattered radiation. The other part of the technology is to use the eye detector. The detector, there is detector on the glasses of the operator, and this will follow where the eye of the operator is going and going to the area on the screen, and then send the message back to the tube to concentrate radiation only in this area and give less radiation around that. Let's see the video of that. This is the eyeglasses of the operator, and it's following the sensor, and with that is concentrating on this area at the tip of the wire, and then keep following that until he inflated the balloon. And once he inflated the balloon, it's concentrating only on the balloon area, and that's concentrating on the balloon area, and there is no there is less radiation around that area. So this is we talked about the intensity. Let's talk about the time. Try to avoid heavy foot syndrome. Don't put your foot on the pedal, and try to put the pedal on your left side. So, and use your left foot for this may give you less radiation. And decrease also the frame rate. Usually we are using now the frame rate of 15, but however, if you decrease that to half, to 7.5, you'll decrease the amount of radiation. This, see the comparison between the dose of radiation here when we decrease to 7.5. There is that will cause a reduction of the radiation dose by 30%. To the operator and by 20% to the patient. The third point about radiation control is the distance. There is what we call the inverse square law between the distance from the radiation source and the position of the operator. So try to be as far as you could from the radiation tube. This is by just using simple tube extension, and putting the manifold away from the hand and the source of the radiation. That will protect the operator significantly. Also, while getting the access, don't put your hand directly and under the tube, and you can there is some special needle that you can use. That needle, let's do there is special needle that you can use that needle to get the axis, and has needle extension. Look at that needle extension, so you don't put your hand under the X-ray source, and you can get the axis. And once you get the axis, you put the wire, and that he's inserting the wire now without any radiation, because he's already inside the vessel. So this is the special needle to get the axis. The fourth part is the shielding. The shielding is very important for your protection, since there is a lot of scattered radiation from the X-ray tube around the tube coming to the operator. So try to use the shielding. There is the ceiling shielding, and there is skirt shielding, and try to keep that as close as you can to the patient. Look at this picture. The shielding is away from the operator and away from the patient, so there is no benefit of that shielding. This is the right position for the shielding, and this is the ceiling shielding, and together with the skirt. Using the rad pad, reduce the radiation, scattered radiation coming from the at the axis side, and this is the right position for the shielding. Now, using the head protection, there is a lot of study, but the head helmet could be heavy. Using small radio absorbent caps may give you some protection, but only reduce the radiation dose by 3%. But if there is a good radiation hood, that may reduce the brain radiation up to 55%. Using the eyelid glasses with which is rounded around the forehead, give more protection, and 61 reduction to the radiation to the brain. Now, concerning the hand, there is a special cream that gives radiation protection, and this is a cream put in the hand. And look, but you cannot use a glove, lead glove, because that may give you a lot of radiation to penetrate your hand. So there is no point to use leaded gloves, but use cream protection for the hand. Now everybody's talking about the Shin protection. There are some protection for the shin, especially for the long operation, especially if you're doing peripheral intervention and abdominal aortic aneurysm intervention. You may need to protect your shin. Now there are this zero gravity protection, which prevent you from wearing heavy lead. It's coming from the ceiling and give you protection without wearing any leads. Look at that nice movement for the operator. The other thing now which coming new is the robotic intervention. You sit in the cockpit without any radiation protection and do robotic maneuver for the wire and the catheter and the stent from the cockpit without any radiation exposure. And there are some studies that following this intervention, you may reduce the radiation dose by up 95% of the radiation dose. So those are the four important things: the intensity, time, distance, and shielding. Now there is important point that you can use to give you an alarm that there is radiation going on, especially for the staff around you. And there is this special machine which beep once there is radiation on, and that's everybody get attention that there is radiation going on. There are some special monitors that monitor every staff while they are working in the Cath lab. Apart from that, the education is the answer. Try to educate yourself about the radiation physics and the kind of radiation protection and the dose of radiation, and with that you prevent the injury. Just remember, radiation is bad. It may cause skin injury, cancer, and that's what we call deterministic effect, and that's related to the dose. But we call stochastic effect, which has nothing to do with the dose. It may happen just with one dose, but the incidence is related to the dose. There are many action and technology that can be used to minimize those hazards. So try to learn of them and do something today to prevent anything from happening tomorrow. There are some points about staff protection. Try to get good care of your lid. Don't keep it in this situation. This is very bad and may cause the lid to be damaged and cause a radiation leak. Try not to put your hand under this. This is, look at this hand. It's a lot of radiation coming to the hand. Apart, forget that the doctor kept his ring in his finger, which is against the law, and that may affect infection control. But this is very bad action to be done. Try to learn about the dose. Please don't use the fluorotime. Very bad way to assess the radiation dose. Try to remember the good things about the air kerma or the air kerma products, which mean the amount of radiation coming to the air or the product amount of radiation coming to the area around the patient's skin. And that's the units for that, either the gray or the gray by centimeter square. So this is keep on look for every patient, every study, that what fluoro mode that you used, what's the frame rate, what's the fluoro time, and what's the area product and the air kerma, and keep in mind those. Remember, using special angulation reduce the dose of radiation. So try to avoid steep angulation, whether in the LAO or steep cranial. Look, just changing the angle from just 45 LAO to 30 LAO, reduce the amount of radiation by around 40%. And keep the distance and keep them. The third most important part is try to use radiation only when you need it. Look at this picture. They are doing IVUS, and they are looking at the monitor of the IVUS, and the monitor of the radiation is where I took this picture, but the X-ray is on, and they are doing fluoro with no need, and everybody is looking at the IVUS machine. So this is very bad practice, and try not to use it. There are a lot of definition for radiation units, but I don't think there is time enough to discuss that. We'll leave that for the discussion. I'd like to thank you for your attention, and I'll be happy to take any question. Thank you very much.
Do you do regularly, Dr. Walid, in your lab? Do you have always teaching session and a reminder of the radiation safety to your staff, or do you measure also the exposure of radiation to each staff? And if one staff has exceeded the radiation dose, what do you do?
Okay, thank you very much. All those things, or those points that you brought up, are very important. I think. There is whenever I go to a Cath lab, I do radiation safety lectures to the staff in the Cath lab, and during my first case with them, I try to teach them that I will not start anything unless there is all the shielding is ready, whether the ceiling shielding or the skirt shielding. Whenever I start the case, I always teach them that the table should be up, away from the tube, and I never accept the II or now the flat detector to be high, always close to the patient. And then reducing the amount of that's very important. I try to teach them how to use the fluorosafe, and I will try to refuse doing frequent semi or using even the what they available stent boost quite frequently to assess how are you inflating the balloon or the post dilation balloon. Stent boost only loads in the cath lab. You may need it quite frequently, but only done once after the stent and then do further decision. Now for the monitoring the dose, some cath lab use two badges, one external at the neck level and the other one internal at the under the lip at the waist level. But I think that's create a lot of problem and confusion. The staff may switch those badges, and so I prefer to use only one badge, and we follow that. And depending on the dose of radiation, I think for the staff, whether they are the X-ray technician or the nurses who of radiation, it should not be that high, especially if we always tell them to be away, just away around 2 meters from the radiation source. Now, the problem comes to the staff, to the especially the operator or the new doctor joining the cath lab. And those need further work. Whenever they exceed the special dose, you'll send them a letter and discuss that with them and follow that. It's not when we reach a high dose, that doesn't mean we need to take the person out of the cath lab, but that's we need to turn his attention, because the risk is accumulative, and depending on how many years you are working in the cath lab, it's not just
very good, Dr. Walid. Very good. Thank you very much. Thank you.